All right. Good day, guys. How are you? So today we are being joined by Dr. James. I do not want to butcher his last name, but I was hoping, Doctor, you help us just give us a brief introduction, your name and your current position right now.
Okay, my names are James. Surname is Nkurunziza. I am a trained cardiologist, and I'm currently actually doing a fellowship in interventional cardiology in Canada.
Oh, okay, that's great. So the next question is, would you please paint for us just how you started all the way to medical school up to where you are now as a fellow?
Sure, yeah. So I finished my high school back in Rwanda in 2000. I'm Rwandese by nationality. And then in 2001, I joined the university back home in Rwanda.
Okay.
And at that time I went straight into medical school.
Okay.
And then, so I graduated in 2008. That's when I got my medicine degree.
8 years later?
Yeah, those were like 6 years.
6 years?
Yeah, 6 years, yeah.
Okay.
So end of 2001 and beginning of 2008, yeah.
Okay, yeah.
So that was my medical school. I can say that during my training, this was like a very few years after Rwandan genocide, and obviously it was a country which was still reshaping itself. There were not so many mentors in medicine. However, we definitely appreciated those who were available and those who were always keen to guide us and give us guidance. I will say that medicine started to make more sense when I started my internship, because now the theories, the years of theories were behind. It was now more practical. Okay. So that one-on-one interaction with patients started to be enjoyable in my internship time. Okay. And so when I completed that, I got a job as a general practitioner back home in Rwanda.
So you completed the internship in Rwanda?
Yes, yes.
And it was for 1 year or 2 years at that time?
That time it was 1 year.
Oh, 1 year.
Yeah, I think now it has changed to 2 years for standardization. Yeah, but it was 1 year.
Okay. Then you became a general practitioner, yes?
Yes, I became a general practitioner, and I was deployed to work in a district hospital. Okay. So it was a general hospital where we used to do everything: internal medicine, pediatrics, minor surgery, and obstetric and gynae. So obstetric and gynae predominantly was related to normal deliveries, cesarean sections, and those who come with miscarriages, things like that. Okay. And then general internal medicine and things. So again, that was definitely much rewarding whenever at any level you are able to help your patients. And however, I could definitely notice the limitation of being a general practitioner. Okay. And I felt that I had to focus in a certain area of medicine so that my capacity is much more focused. So then I got an opportunity to go for a specialization. Okay. So this was my government in Rwanda, which just opted to give us a bursary. So we went to South Africa.
Sorry, doctor, that's after how many years of working as a GP?
I worked as a GP actually for 1.5 years only.
1.5 years.
Yeah.
Oh,
So
interesting.
yeah, so I think I was probably kind of lucky enough to not take so much time in that period. Certainly, it's also okay to build up your general medicine practice so that you can grasp everything nicely. But you know, it's also not bad to go straight into specialization. So in August 2009, that's when I went to South Africa to do internal medicine.
To which university was it?
So this was the University of Witwatersrand in Johannesburg, generally known as Wits University.
Yes.
So initially, also it was not easy to make a choice which specialty to pursue. Especially
you were given a choice on what to choose.
So during my internship, I was still not decided.
Yes.
During my gynae rotation, I would feel like compelled to do gynae. My pediatrics also got somehow I felt interested. And so I was kind of interested in most of the things. Actually,
very common among medical people.
So it's not uncommon to find it difficult to choose. And I remember before I went to South Africa, back home I had gotten an opportunity. Actually, I had applied to go for surgery. I had even was even selected to go for postgraduate in surgery back home. But before they could approve that, that's when the process of going to South Africa had started. Then I weighed the options. Obviously, South Africa being much more equipped in terms of postgraduate training, I felt that let me rather take that option. So I went to South Africa, and initially I had applied for pediatrics, for surgery, for internal medicine. So I was totally confused. But then finally there was someone, a Rwandese guy who was doing his cardiology training in South Africa. He came and spoke to us. We were a group of young people. Then he spoke to us, said, no. If you choose to do something, you must stick with that so that the professor who is checking your application sees that you are committed to one thing, not to everything.
It's true.
So, and that was the result of not having mentors. You know, when you don't have mentors in life, then your life is not focused.
It's true.
So that was really the result of a country which was post-genocide, and we were still lacking in that area. But he was very useful then with that. When he spoke that, I think he spoke sense into me.
And then,
I deliberated and said, I felt that I'm much more compelled to do internal medicine. That time, the reason why I thought of doing internal medicine, I felt that with internal medicine, there is more one-to-one interaction with patients. Especially that treatment of internal medicine is mainly how you do your history taking, your clinical examination, the medication you administer. Yes, surgeons also, they do interact with patients, but since physicians, they really rely on their medications and how they talk with patients. So I wanted that one-on-one interaction. And the reason why is I'm a Christian by belief, and I felt that medicine is not only a job, but it's a kind of a call. And that interaction with someone is so crucial, because you are dealing with vulnerable people who want really to hear a compassionate doctor. So I felt that internal medicine will really make me achieve such kind of passion. Yeah, so I went to South Africa in 2009, and I started in internal medicine then. So I would say that to adjust into South African system was really not easy.
Why is that though?
So first of all, when you come from a foreign country, you go to a different country, the setups are completely different, systems are completely different. The way people relate to you might be very different. The other thing at that time also, my English was very, very weak. So to adjust to English was also a big challenge.
What language did you attend the medical school in though?
So my high school was predominantly in French.
French, okay.
And then medical school, that's when English was very much getting adopted in my country. Towards as we progressed, it started becoming 50-50 English and French. So with that background, then I was more French inclined than English. So
I see.
And then to adapt myself to South African setup was kind of a bit challenging.
Okay.
And probably a few people were not so much supportive. So as a foreigner, you couldn't feel so much welcome. But however, there were many others who were very supportive, and I'm always I always recognize such type of people who will work with someone junior and help them to achieve their dreams. Yeah, so it was a bit of a challenge, but in me, again, as someone who believes in God, I knew that whatever challenges I may face, those should rather be a motivation to make sure that nothing should hinder my dreams. So, in this life, you don't get things smoothly. So, and when you go through tough situations, it makes you stronger. So, but I will say that we had to read our books to be at the level which was expected. The volume of work was extremely overwhelming. However, what I will say is South Africa is a great place for postgraduate training in the sense that there is a significant hands-on. So you do many procedures in your training. You are kind of left on your own to do many things. There was a principle which they used to say that if a procedure, you see one, you do one, you teach the third procedure. So
interesting.
There were not many like spoon feeding that the one will show the procedure for 10 times. No.
Was it also because it was understaffed at that point, or it's just an African thing?
Yeah, yes, there is understaffed, but I think probably it's a setup. It's a system which is set up like that, which is not optimal. I still think that junior people will be properly guided until they are confident enough to handle things on their own, and also to acquire skills in a more controlled manner rather than a bit catastrophic.
Yeah, it's safe.
Probably later on, I will compare it with my experience here in Canada. I will say a few words about it, just to compare and contrast. Yeah, but definitely it was a great system. We had good professors. We had many tutorials. Obviously, there were those who were so keen to teach, and many others who were, a few others who were not keen. And that's why in life, as a student or as a trainee, you always remember someone who has contributed into your training. So I still remember from my high school up to now, I always take note of those who take time to teach you. So I did my internal medicine and finished that in 2014, May. the exams there are tough, are really tough.
Are they OSCE based in writing or both?
So in our time, we used to write 3 written papers. They were, that time, when I started my exam, it was a MCQ. It used to be short note, but at that time it was MCQ. Okay, first of all, there is part 1 and part 2 in internal medicine. So part 1, it used to be two papers, which are now currently MCQs.
Okay.
And yeah, and then part 2, there were 2 papers, OSCE and another written paper, which are case-based scenarios, and then so they give you clinical scenarios and then you will answer. Okay. So you really had to cover a lot. And you had to cover that with a very busy training schedule. In other words, you work like most of the day up to 4 or 5 p.m. and then you go home, rest a bit, and get a few hours to read afterwards. So you had to really manage your time efficiently. Otherwise, you would end your 4 years training without doing your exams. And so it was a very, very tough, but a very, very efficient program, I would say. Okay. I would definitely think that South Africa is a great place to train. Okay. So I completed that. So after the written, you do a oral exam. In our time, they used to give us 3 cases, 2 short cases and 1 long case. Okay. The 2 short case, each 30 minutes of examination and then 30 minutes of being evaluated, and long case, they will give you an hour to do a full examination, and then they will ask you questions. Okay. Yeah, so it was a very stressful, but obviously exams are needed to sharpen your studying and your knowledge. So, yeah. Any question maybe at that level?
No, I just wanted to say on your point that you said you always remember the people that have taught you. That is very true, because you, up to this day, I'm still remembering you. As little as the time we're exposed to you, we have really learned a lot. Cardiology, you have probably taught me the most cardiology than I've ever had anywhere. So definitely I can relate on that one, and I'm also very grateful for that.
No, sure. No. Again, my motivation for teaching students were like for a couple of reasons. Now, number one, I remembered how in my undergraduate, it was a big challenge to get someone who will teach you. So I didn't want young people to suffer like the way I suffered. So I felt that maybe if I'm alive, let me make a difference in someone's life.
And indeed you have.
Yeah, number two, as a Christian, we should not be self-centered. We should give to others. So whatever you know, just share with others. Number three, we should, medicine is about academic development. So know that I may teach one thing today, tomorrow you may be the pediatrician of my children.
It's true.
You see? So it comes back to you. So, and develop our societies. So really we need to think like that, not be self-centered and forget people around you. So we should give, because that's the principle of God. Yeah. So so then when I finished internal medicine, I think about going back home in Rwanda. And then I said, if I go back to Rwanda with internal medicine only, I'm sure there are many physicians. Rwanda, they were training many physicians there. Then I weighed how much impact would I contribute with my internal medicine only? Yes, definitely you can contribute as a physician. I'm not undermining that. But I said, let me think about the subspecialty.
Okay.
So again, during my internal medicine training, I weighed my options and saw which subspecialties, because internal medicine has many subspecialties.
Yes.
There was endocrinology, there was in pulmonology, rheumatology, nephrology, gastroenterology, and cardiology, infectious disease, hematology, oncology. So there are so many, intensive care. So I thought maybe I need to think about one thing which should make me have an impact wherever I will be in life. Okay, then I felt much more compelled to doing cardiology.
Is it that because you loved it more than the other one, or you thought that's where you give the most impact?
Yeah, so a great question. You know, as I was doing my internal medicine, I realized that I was more prone to doing things, procedure-based practice.
Okay.
And then I thought that maybe probably I should have enjoyed the surgery much better than internal medicine.
Maybe.
Then I, with that, I said, okay, probably cardiology is one of the internal medicine specialties which have a lot of to do as procedures. And then that's how I felt like much driven to doing cardiology. So, you know, in life, you keep discovering yourself.
Yes, yes.
Yeah, so that's how we evolve in life, really. And it's good to keep assessing yourself and see how things go. Yeah, so that's how it went. And then, so I felt much more compared to either doing cardiology. My second option was gastroenterology.
Okay.
Because gastroenterology has a G-scope, has a C-scope, has a ERCP, and many others, many biopsies, things like that. So I felt like more compared into that. But cardiology was much more appealing to me. So then I went to cardiology.
So it was just that easy to apply into cardiology.
Yeah. So there were two things. First, to get a post, and secondly, to get a sponsorship.
Yeah.
So I had to weigh into those options. So like I applied in one place, and I was not selected straight away.
Okay.
They were giving me time to wait, but I said I don't have time to wait. And then I went to apply to another hospital called Baragwana Hospital. There was a professor. It was my first time to meet him. I went straight to him. I said, I just finished my internal medicine. I'm interested in cardiology. If there is a post, please consider my application. Okay. So we just sat like for 30 minutes in his office. Then he said, okay, let me speak to a few people who know you. Then I will get back to you in 1 week. Within 1 week, he gave me a post. And so he's one of the people whom up to now I still remember. He's my role model. He was such a humble and a kind professor who was always keen to teach us. Whenever you need his help, he will be there for you. So he's my big, he's a big person in my life. So he gave me that post. I had a few challenges about sponsorship at that time, but also God as a provider afterwards. Again, that professor assisted me to get sponsorship. And then I started cardiology July 2014. Okay. So that was 3 years of training. Yeah, so cardiology itself, when you start it, is also very intense. When you start
I thought it would be easier with
no. You know, unfortunately, the moment you start a new specialty, you feel like a baby who is now learning how to walk. Oh no. So I had to learn to do echocardiographies, cath lab procedures, pacemaker implantation, now a focused cardiac patient management. Very, very, very stressful. Yeah. And some cardiologists behave a bit rough, like some surgeons. So some who are kind of rough, then you like feel like very, very intimidated. And so some were very supportive, some rough to you. So, but it was very enjoyable. It was very enjoyable. I had to read seriously. Like there were many textbooks for cardiography, many textbooks for cardiac catheterization, many textbooks for cardiac arrhythmias, many textbooks for guidelines in various management of patient, valvular disease, ischemic heart disease, so many things. So again, it was very intense, but with cardiology, I found much fulfillment. So you do echoes, you could do like more than 10 echoes in a day. At least the first 6 months we were doing echocardiographies. So you do as many as possible. And there the things which I learned in internal medicine of cardiomyopathies clinically, valvular disease clinically, hypertensive heart disease, pericardial diseases, ischemic heart diseases. Now to see them on a cardiography, it was really much of a fun. So I enjoyed it. It was very, very fulfilling. So I enjoyed that part. And after a certain period of time, we started, after 6 months, we started doing cardiac catheterization. Cardiac catheterization is also very enjoyable. However, it's an invasive procedure where you can have a complication of various degree, from minor bleeding to severe bleeding to aortic dissections to cardiac arrest to even someone having a death on a table. So it's kind of intimidating, but there were senior people who were supportive. So also very supportive in that sense, pacemaker implantations and many other things. And then managing acute heart failure, acute myocardial infarction, and acute arrhythmias. So it was very, very enjoyable, really. So I think I found myself very much happy in my cardiology training. So again, we had to do a final exam, which was like to prepare a cardiology exam. It is like preparing to meet a lion. So it's really, really hard. Oh my goodness. Yeah, but again, what I found useful in all of this trajectory was that to study continuously, like study continuously and learn case by case. If you meet like a myocardial infarction, read about myocardial infarction, its complication, presentation, management. So one case, because when you read about the case, that's how you can remember things. Because exams are about clinical case scenarios, so they will come back like that. So, and then also read as you progress in your training. Don't wait until
the end of the
yeah, when you wait until the exam, oh my goodness, then you'll be overwhelmed. You can even feel depressed. Yeah, so it was a hectic exam, but I thank God I completed it successfully on my first attempt.
Well, that is
and so I finished it within my training time. So when you pass the cardiology exam, the celebration, you feel like
out of this world.
I'm telling you, you feel like you own the world. Oh, it was a huge relief. It was a huge relief, yeah. So yeah, so then I completed my exam in October 2016, and I had to complete my training time up until mid 2017. Yeah, so after exam, you are much relaxed. Now you are polishing up your skills and learn more. Yeah, so when I finished that, and I got a job in Namibia. That's how I came to
So
Medipack.
immediately already got a job in Namibia.
Oh yeah, yeah. When I finished,
That demanding.
yeah, sure. No, you can't. Cardiologists are still in a big demand in many countries. In many countries, definitely. So I got a job in Medipack and joined Medipack in November 2017. Yeah, so I think maybe I can stop it there for now.
Okay. Yeah, I just wanted also to find out how many years have you been practicing now?
Oh, sure.
Cardiologist.
So I practiced from November 2017. So up until October 2020, that I was in Namibia, mainly based in Medipack. I was also doing part-time in Oshakati Hospital.
Yes.
Yeah, someone and Joko patient which also sometimes come to Medipack or go to Oshakati. So I practiced close to 3 years.
Okay.
And then at that time, I also again felt that maybe let me do a fellowship in cardiology. That's why I pursued this.
Okay. Yeah, that's a very comprehensive story.
Yeah,
it's very interesting to hear.
sure.
Yeah, I think you even answered some of the questions here. I just wanted to also find out how many cardiologists are in Namibia total.
So at the moment, the ones I know, I think there are 3.
There are 3.
Yeah. So I think there is one in the Medipack, one in Redi Pohamba, another one in Roman Catholic.
Catholic, yes.
I'm talking about adult cardiologists.
Adult, yes, yes.
Yes, yeah, and because there are 2 pediatric cardiologists, one in Medipack, another one in Windhoek Central.
Okay.
Yeah, and if I'm not mistaken, there should be another 4th cardiologist who should finish in South Africa. Yeah.
An adult one.
Yes, and that one, yeah.
Okay, so it will be coming soon.
Yeah.
Okay.
So and among those 3 who are in the country, I'm not one of them. So I'm outside now.
Yeah, you're outside.
Yeah.
Yes. I wanted to find out also, can the state hospitals really accommodate adult cardiologists? Are there facilities that can actually accommodate adult cardiologists at this time?
Oh, sure, yeah. Actually, I would say that public hospitals everywhere in the world, I think they deserve to have more cardiologists than private hospitals because that's where the bulk of patients is. Like patients with gross pathologies who are somehow helpless. And I'm saying this because my time in Namibia, I've seen the number of patients in Oshakati. I've seen referrals from Monanjokwe. I did one outreach in Rundu Hospital in 2019. I also did one in Katima Muriro Hospital. I know what happens in Windhoek Central Hospital. I'm sure same as Katutura. So the number of patients is extremely overwhelming. And these are patients who really need very, very specialized care. Because unfortunately, they arrive at the later stage of the disease progression. So they really need someone who will be able to tease out many issues and help them optimally. Yeah, so, and yes, there might be facility issues, but there are basic equipments which are available at least in Oshakati, and then Vinduk Central, I think, is much more equipped.
Okay.
So yes, I would definitely say that they are actually lacking a lot in not having a big number of cardiologists.
Okay.
Yeah.
Also, I wanted, could you please paint for us when you are practicing at Medipac, what a day in a life, a normal day of a cardiologist, maybe what time you wake up, how you start with the hospital, what you start with, and up to how the day ends. Just a brief picture.
Oh, sure. Yeah. So the day for my daily life when I was there, so Medipac was relatively busy, not hectic, really.
Okay.
So it wasn't extremely demanding.
Okay.
However, I would always reach the hospital at 8 in the morning, and mainly I will see my patients who are admitted, and the large number of patients were heart failures, predominantly cardiomyopathies. Direct cardiomyopathies were the big part of them who will come with congestive heart failures, few valvular heart disease, few infective endocarditis, few coronary artery diseases. So those were the big number of patients, and then few arrhythmias. So I will do my ward round, and then after that, I will go do the clinic. Okay. So, and the clinic was mainly based on the outpatient clinic was based on there were new patients and follow-up patients. Okay. So follow-up again, the big number was those which I've said were admitted cardiomyopathies of various causes and valvular diseases, those with previous surgery, and then we had new patients who would come with new heart failure, new chest pains, a new arrhythmia presentation. Okay. So palpitations were like a very common symptom there, as well as the chest pains and shortness of breath, obviously. So it was like an outpatient-based practice. Okay. It was the outpatient practice was much more busier than the inpatient. Yeah. And then 1 or 2 days, I will be in cath lab doing certain procedures. Okay. Yeah, I think you have a question on that, which maybe I will elaborate when that question comes. Yeah. So, and then our practice was based on obviously physical history taking, physical examination of our patient. We had the ECG, 12-lead ECG. We had the Holter ECG for those who needed one. We had the stress test ECG for those who needed it. We had the cardiography for those who needed that. Yeah. So again, it was like a very dynamic practice. Okay. So I will see those type of patients, and at least in 30 minutes you will figure out that someone either has a serious problem or is out of danger. Okay. So it's a specialty where you can really figure out reasonably quickly. Okay. What's happening with someone. Obviously, there are some cases where with diagnostic challenges, but those are exceptions. Okay. Yeah.
On average, what time do you knock off?
Oh yeah, it was I'll knock off around 5 p.m.
Around 5 p.m. And I also wanted to know for emergency cases, maybe there is an acute coronary syndrome that arrives in the. Are you the first to respond, or is it the emergency specialist?
Oh, sure. Yeah. So it depends on where the patient finds themselves first. Okay. If they present to Medipac, they will be received by those working in emergency room. Okay. So they will be the ones who will assess first, and then they will call us. Okay. If it was if patient presents to outside hospital, they will phone me.
Oh.
So that's how it used to work.
Okay.
Like those from Rundu, those from Ondangwa Private, those from even Oshakati, Onandrokwe, and Tsumeb, all those hospitals, they will call the cardiologist on call.
Okay. And you were two of you at that time?
Yes, we were two of us. There was Dr. Artia.
Okay.
So we used to do 1 week call. I would be on call for 1 week. He would be on call for the other week. So that's how it used to work.
Okay. I see. Okay. I also wanted to find out what are some of the bread and butter cases. I think you have touched on it actually.
Yeah. So the bread and butter cases, again, maybe I can also include the Oshakati scenario, because we used to go there Mondays and Tuesdays and Thursdays. So both in Medipac. So Oshakati may be state hospital.
Yeah.
They were predominantly heart failure syndrome. So heart failure syndrome was the big presentation.
Okay. And
then from that, cardiomyopathies, heart failure of reduced ejection fraction were the biggest cause of that. Secondary, it was valvular heart diseases, like rheumatics in young people was a big problem. And then a few cases of infective endocarditis coming as heart failure. Okay. And then a few cases of pericardial effusions, mainly pericarditis, few constrictive pericarditis. Okay. So those were like for the heart failure syndrome. Okay. And then we had also arrhythmia patients. Okay. Those who will come with bradyarrhythmias, predominantly complete heart blocks with syncopes, dizziness, fatigue, and either shortness of breath. So we also saw those patients, not frequent as heart failure, but definitely it was a big number of them, especially elderlies in state hospitals. So we used to see those patients. No. And then those with previous valve surgery, they were a big number, especially in the state. And then previous bypass surgery, we also used to see them.
Also, they are seen by a cardiologist, not by the people that operated.
Come again?
The post-surgery patients. So they are also, because most likely they operated by a cardiothoracic surgeon.
Yes.
So the cardiologists are the ones that normally follow them up.
Yes, usually they're followed up by cardiologists. The cardiothoracists will follow them in the first days when they are recovering from the operation, but afterwards the care is taken over by cardiologists. Okay. Yeah, so that was the bulk of patients. And then chest pains. Chest pains were like those with typical chest pains. Those with typical chest pains were really, really frequent. So those were type of cases we used to get. Okay.
Could you also mention some of the common procedures that cardiologists normally do?
Yeah. So the procedures were based mainly on the different diseases of the heart. Okay. For arrhythmias, for example, procedures we will do for the tachyarrhythmias. Apart from pharmacological treatment, we also do cardioversions. Okay. For those who come maybe with hemodynamically unstable tachyarrhythmias, definitely you do cardioversion. It's also it's a life-saving. It's one of really something which is very rewarding. Someone comes like in a critical state, you do cardioversion in a just matter of seconds, someone comes back to life.
I wish, to this day, I wish I could see one. I've only ever read electric cardioversion.
Is it? Yeah. No. I think you guys, please train yourself now. It's very easy. You can go to YouTube and see how to manipulate a defibrillator. It's very easy, life-saving. I'm telling you, in my life here in Canada, I have seen they have a very nicely structured systems that defibrillator does wonders. It really, really does wonders. Yeah. So the cardioversion was a big thing. It was a big thing, not so common, but definitely was life saving. So that's one of the big procedure. And then, as far as bradyarrhythmias are concerned, we will do temporary pacemakers for those who come unstable with bradyarrhythmias. We do temporary pacemaker. Those who are for long-term purposes, we'll put a permanent pacemaker. So that's also very rewarding because you can change someone's life by implanting a pacemaker.
So these cardiologists can insert a pacemaker?
Yeah, for sure. Yeah. Yeah. So
you do it percutaneously or? Do you do it percutaneously? Or?
Yes. Yeah. So pacemaker, at least at this stage, predominantly is percutaneously. So for the permanent one, we usually go subclavian via subclavian or axillary vein, where you puncture here, access the vein. If it's a single lead pacemaker or a single chamber pacemaker, you take the lead from the subclavian all the way to the SVC, right atrium, through tricuspid valve, right ventricle. You put it at a place either in the apex or in the septum, at a place where it is pacing the heart optimally. So there's a machine which you use to measure if it is pacing optimally, and then you know that your lead is secure. Then you can suture it in and put the battery on, and then it stays like that. So we put it transcutaneously. A temporary pacemaker, you can do it through the femoral vein, where you go up to the right ventricle or internal jugular. Yeah, so it's a great thing. Now I think they are getting subcutaneous ones, so things are really growing. Yeah.
That's interesting. Yeah, so those are some of the common procedures that.
Yeah, so those are for arrhythmias, and then for echocardiography is like really something which is a bread and butter of a daily routine, whether it's a transthoracic echocardiography and then a transesophageal echocardiography. So that was like a daily imaging modality. And then cardiac catheterization for those with heart attacks, those for hemodynamic assessment for valvular diseases. So if we take them to cath lab for angiogram.
Okay. I was also hoping, are there any misconceptions surrounding cardiology that you are aware of?
Yeah, probably not so many. I think many people have a general idea of who is a cardiologist. If it's a general public, they may figure out when to consult a cardiologist. So the only misconception is maybe to think that a cardiologist does open heart operation. No, those who do open operation are cardiothoracic surgeons.
Thoracics, yeah.
Yes. However, nowadays cardiologists, I know there's a question in that sense. Cardiologists are also doing many procedures which used to be done by cardiothoracic surgeons. Yeah. So that was a big thing, and so in life, many patients will think that a doctor who doesn't operate is not a doctor. So that's why they may put in that category. But we do many things which are life-saving. The only misconception which I will think, as far as colleagues are concerned, is to think that everyone who presents with congestive heart failure is should be treated like a dilated cardiomyopathy, where they get anti-remodeling therapy. So congestive heart failure is a syndrome is the manifestation of many things. Can be pericardial disease, can be valvular disease, which needs surgery, can be infective endocarditis, which needs antibiotics, can be diastolic heart failure, which doesn't need beta blockers or ACE inhibitors. So I have seen many patients who get delayed in district hospitals. They have been given all those medications because people try to put them in the same basket. So that's a presentation of many various underlying cardiac causes. So they need to get assessed properly, and then a patient can get a proper tailored therapy.
Okay, that's interesting. And another question was, how is the overall compensation of a cardiologist? Would you say it is decent or it is poorly compensated? Just a general impression.
Yeah, you mean a cardiologist, isn't it?
Yes, as a cardiologist.
Yeah. No, I think obviously depends on which country one is working from.
Yes.
If one is working in North America, their salaries are extremely good. So you can't, yeah, but I think they're physicians, any physician, I think you earn a good money. So difficult to put it on an African context. So it depends on country income, but in general, cardiologist is a very fulfilling financially. You know, obviously it depends on people's satisfaction. So sometimes we want so much, but for me, I was satisfied as a cardiologist.
Okay. I mean, that is good to know. What is the hardest thing or perhaps least attractive thing about being a cardiologist? What do you not like about it?
Okay. The only thing maybe which may be a bit challenging, if you work in a place where you are on your own and it's a busy place, and you are on call because heart attacks happen anytime, that can be socially depriving. Yeah. However, if you are in a place where there is a good number of you, where you can alternate, that problem is alleviated.
Okay.
So that thing, I don't think it's really too much.
Okay.
There is those who also can think that sometime we may have a patient who will come with refractory heart diseases and try your best, but you don't achieve your objectives. Also, that one shouldn't be seen negatively. As long as you have done your duty and done your best to help your patient, you shouldn't blame yourself if you haven't achieved what you intended. So that one can be a little bit depressing, and sometimes you may get a heart attack patient who may die like suddenly in front of your eyes. That can be very traumatizing. In that sense, I always compare cardiologist to an obstetrician. Who obstetrician, they may also get a pregnant lady who comes, is talking, is fine, but can get an obstetric complication and die like in a twinkling of an eye. So heart attacks can also do that, or any heart disease. So that one can also leave you devastated. So those are the things, and you can also get a complication. Unfortunately, for cardiac catheterization, you can get those complications, and you may lose someone's life, and that is devastating. But you need to know that that's the profession, that's the nature of the profession, and that should also keep as a humble human beings.
Mm-hmm.
You know, sometimes when you're in a profession, you think you are a hero.
Yeah.
There is one of a professor of mine in South Africa. He's a hematologist. This is one of the professors also I will never forget. He was a very brilliant professor. He will teach you about hematological diseases, like any detail you will ever imagine. But he used to say that medicine is a humbling profession. Yeah, so that's medicine. So if you have seen an arrogant doctor, I don't know which word they're operating from, because medicine is a very humbling profession. So you need to stay humble. You need to know that you are limited as human beings, and you surrender your matters in the hands of God, because when you've done your best, know that things can happen, and not you're not on control of everything.
Okay.
Yeah.
What is the work-life balance as a cardiologist? And probably there it's better to compare someone in private practice, work-life balance, from someone in where you were practicing, people that are in the state, how the work-life balance is. Is it too demanding, or you get to have other things outside of medicine also?
Are you talking about being busy, comparing state and private, or are you talking about?
Yeah. Number one, maybe let me ask them in a series of questions. How is the work-life balance of a cardiologist in general? Are you able to balance being home a bit, maybe with your family, doing other things outside of medicine? Or you are always just working?
Oh, sure. No, definitely. And again, everything depends on how you organize your life. And what are the priorities of your life. What I will say, I know many people will think that clinical medicine in general will deprive you from social life. Yes, I know there are people who may work in private sector, and then they will chase money like crazy. Even the money they have worked for, they are not able to really enjoy it. I don't think that's also good. So we need to balance that. And obviously give your profession a priority, because you need to offer your best. And secondary or firstly, know that your family, if you have a family, me, I have a family. So I value my family. I know that the social well-being of my wife and my children definitely depend on my presence. Yeah. So, and I will say that so long, yes, when I was a student, like now, I'm kind of far away from them. When I was in South Africa, we were together, but it was too demanding. But when I was practicing in Namibia, it wasn't really too overwhelming that I couldn't find time for my family. So again, it depends on how you manage your time. So because for me, it was my work, my family, and then with my family, prayer time.
Okay. So basically, outside of medicine, outside of work, is the family. You are very religious, and those things help you balance your
yes
home.
Yes, because me, I'm not into football. I don't. I know many people have football every evening. You need to watch Champion Leagues and everything. For me, the only football I watch is the World Cup. So
everyone else in the world does.
Yeah, so that's the one I watch. But otherwise, I finish work, I go home, I spend time with my family, spend time with God every morning. And then Saturdays, usually that's time I dedicate for prayers. Yeah, and I find that very much fulfilling to me. And that has actually been so helpful, especially during my training when it was so stressful, like even up to now. because when I'm stressed and I meditate on certain Psalms chapters, it really keeps my heart strong.
Oh.
And will tell you, be still, know that I'm God. So whenever I'm challenged, I know that I know where to find refuge. So I can't burn out because I know where to find relief.
Yeah, that's very interesting. I also just wanted, because I think you mentioned you are a fellow now. You're doing interventional cardiology. Yeah. What would you be planning on doing as an interventional cardiologist?
No, sure, yeah. Yeah, so interventional cardiologist is a subspecialty of cardiology, which is on a day-to-day basis growing at a very fast pace.
Okay.
It initially started as mainly coronary artery disease intervention, both from stable coronary artery disease to acute coronary artery disease in the form of revascularization. So obviously up to now, that's still the bulk of daily activities. So that what keeps an interventional cardiologist busy, where you face heart attacks. Like in a place where I'm training here, it's a very busy hospital. Like averagely, you will get like 3 to 5 cases, sometimes even 8 cases of heart attack a day, out of hospital cardiac arrest, who will be shipped like very immediately to the cardiac authorization. Just to go a little bit back behind, what has amazed me when I arrived here, is how even general public, they are very, very trained to do cardiopulmonary resuscitation. We hear many stories of people who will be walking and collapse. Then a bystander starts CPR, awaiting emergency service to arrive. Or someone collapsed at home, the wife started CPR. I have like a patient of mine who has had a cardiac arrest 2 times. First one was December last year. The wife started CPR. Patient arrived at the hospital, resuscitated. Had another cardiac arrest in April this year. Wife started the CPR. Patient arrived at the hospital. Patient is still alive. So with that, so we get so many out of the hospital cardiac arrest due to myocardial infarction. So acute coronary syndrome is really bread and butter here. So that's the bulk of our job, intervention in that sense. And then the other part of interventional cardiology, which is gaining a huge momentum now, is called structural heart disease intervention. So this is mainly valve replacement. It started mainly as a transcatheter aortic valve replacement. That used to be a surgical operation. But now it started for the patients with severe aortic stenosis who are very high risk for open surgery. But nowadays, even those with low risk surgery, they are getting a transcatheter aortic valve replacement. So it's really gaining a huge momentum. Obviously, it's very widespread in developed countries. It still has to catch up in many African countries. I know South Africa does that. The northern, the Arabic countries in Africa, they do that. Kenya has started doing that. Probably Sudan also. So it's gaining momentum. The other thing is there is also transcatheter mitral valve replacement called mitral clip. There is mitral stenosis, valvotomy for mitral stenosis. There is PFO closure or atriosecundum or VSD closure, although those are mainly with congenital interventional cardiologists, mainly pediatric, who may even do those who are adult, but yeah, so things like those. So it's really growing significantly. Yeah, and so it's really, really going at a very fast pace.
Yeah, because before because initially I was struggling between neurology and cardiology. I had made immense research that time for cardiology. One thing I noticed about cardiology was that it has a lot of research under it. It's almost as if there's always something new.
Oh my goodness. Yeah.
It's a lot. So, everything keeps coming. It seems to be rapidly increasing.
Yeah.
It's really
it's extensively researched. Extensively researched. There are big cardiovascular societies. There is the European Society of Cardiology, there's the American College of Cardiology, American Heart Association. Those are the big bodies. There are now Asians and Indians, Africans. We still have to catch up significantly. But those bodies have reached another level.
So they are doing a lot of research there.
Significantly, yeah.
Yeah. What hospital are you doing the fellowship now, and for how many years is the fellowship?
Yeah, so I'm working in a hospital called, it's a city in Ontario, Canada.
Okay.
Called Hamilton.
Hamilton. Okay.
Yeah.
Okay.
I think there's a partnership between McMaster University and
UNAM.
And the UNAM.
Yes, yes.
There were some students who came here before COVID from UNAM. Yeah, so the hospital is called the Hamilton General Hospital.
Okay.
Yeah.
The fellowship is for how many years?
The fellowship is, so interventional cardiology is mainly for coronaries is 2 years. You can get it short if you want a certain level of exposure, but the full training is 2 years.
Okay.
If you want the structural, it's another 1 year.
Okay. Which one do you plan on? What do you plan on doing?
Probably the 1 to 2 years. I will see how it goes.
Okay.
Yeah, I will see if I feel that I still have energy for the structural, I may go ahead.
Okay.
Yeah, because sometimes it's better to finish it once and then you set yourself. Yeah.
Well, are the scholarship fundings for these things, or you have to fund yourself to do these fellowships?
Yeah, you kind of have to find yourself a scholarship.
Okay.
Yeah, depending on which country one comes from. Let's say, for example, if you come from a busy place where cardiology is busy, let's say if you've gotten a cardiology post, I mean, you're working, for example, in South Africa, industries sponsor you very easily.
Okay.
Yeah, even certain hospitals may sponsor you.
Okay. Well, that is incredible. So you plan on finishing this fellowship, then you come back to Namibia?
Yes, yes.
Okay. We hope to see you back again.
Sure.
Are there any other subspecialties in cardiology?
Yeah, so cardiology now has interventional cardiology.
Okay.
Then electrophysiology.
Okay.
So electrophysiology, those are the people who deal with arrhythmias.
Oh, okay.
They are the ones now who deal properly with pacemakers, implantable cardioverter defibrillators, cardiac resynchronization therapy for heart failure, arrhythmias in terms of medical management, ablation of atrial fibrillation, ablation of ventricular tachycardias, atrial flutters. So that one is also growing like a crazy. So that's a big specialty nowadays. It's a 2-year training.
Okay.
And there is imaging. The imaging is mainly based on transthoracic echo, transesophageal echo.
Mm-hmm.
I think they do some cardiac CT.
Oh.
Cardiac MRI and CT used to be a separate specialty, subspecialty.
Okay.
And then there is a heart failure itself.
Is a specialty.
The specialty. So that's where you deal with those advanced heart failure. That's where you deal with cardiac transplant, because the cardiac transplant in these countries is a big thing.
Oh.
So it's a big thing. So it's like a bypass operation in Africa. So
oh, okay.
yeah, and then there is also cardiac critical care.
Oh, okay.
So cardiac critical care is also a specialty. Yeah, so you see, things are growing significantly.
But it's incredible how much time it takes to.
Oh yeah.
Oh, it is, and you are still going. You still seem to have energy. So.
Oh yeah, exactly. You need to keep that motivation and zeal. Yeah.
Okay.
Uh,
And maybe a last few questions. How have you seen cardiology change over the years? Where do you think it's going? Are you going to replace cardiothoracic surgeons very soon? Because it seems a lot of things are becoming now replaced by cardiologists.
Yeah. No, definitely. Cardiology is evolving significantly.
Okay.
Transcatheter coronary intervention was initiated September 1977 by a German guy who was, I think, in Sweden, if I remember correctly, who did the first balloon angioplasty in a coronary artery disease. So that was 1977. But if you look behind from 1977 up to now, how transcatheter therapy has grown, it's exponentially unbelievable. So it's growing very fast, and it's including many procedures which were definitely done by cardiothoracic surgeons. Definitely, there are many other procedures which are still purely cardiothoracics.
Okay.
Many are still there. So, like for example, we get a very severe coronary artery disease, which are kind of surgically amenable, which are a bit too complex for percutaneous intervention. So far, regurgitant valve heart disease mainly are, open heart surgery done. Aortic aneurysms are cardiothoracic surgery. Infective endocarditis is still under cardiothoracic surgery. Cardiac tumors are still under cardiothoracic surgery. So definitely they still have a big role to play. And yeah, but definitely, actually, in the centers here, the cardiothoracic surgeon have started also training themselves to doing transcatheter valve replacement. So yeah, so otherwise
their jobs.
Yeah, exactly.
That's interesting. Yeah, and also if there's a student or an intern or perhaps a junior EGMO who maybe wants to pursue cardiology, maybe do you have any advice for them how maybe they can build their portfolio? I don't know, research or whatever, make them more marketable to be accepted to go into this specialists.
Sure.
Because I'm assuming now there should be high demand, but then probably a lot of people now probably are also applying. I'm not so sure.
No, for sure. Yeah. Yeah. Okay. So obviously we're talking about the African context because, and so far, what I know, the places which train cardiologists are mainly South Africa.
Yeah.
I know Kenya has started training. Probably Ethiopia also. I think Ethiopia also trains.
Okay.
Northern Africa trains. Egypt is very big into that. I haven't heard many people who go to Egypt to train.
Okay.
Probably Senegal also trains. But I think South Africa still plays a big role in many ways.
Yeah.
So first of all, I think one needs to get themselves a great foundation in internal medicine. Yeah, I think that's why where one can start from.
Okay.
Yeah, and it's good to go to a country where you can have the opportunity of having that subspecialty.
Okay.
Because if you go to a country where, for example, let's say if Namibia was doing internal medicine training, and you do internal medicine in Namibia, and then to get a post in South Africa as a cardiologist might be more difficult. And someone who did internal medicine in South Africa, and then wants to pursue cardiology. Because when you have done it in South Africa, you have rotated in cardiology, you know how it works. You know the professors there, they know you. So it's much more easier. And then from that, you can also get exposed to research.
Okay.
Yeah, because if you are definitely inclined into that, those are centers which can boost your research desire, and you find yourself with it. So probably get yourself into a proper training hospital for internal medicine.
Okay, and I just have a quick question there. Which one is harder? Is it harder after you have completed the internal medicine? Is it harder to get a post to do cardiology, or is it harder to get the sponsorship? Which one is harder between the two?
Okay, yeah. So they may be both hard and they may be both easy depending on everyone's circumstances, isn't it?
Okay.
You may be coming from, for example, a country which is ready to sponsor you.
Yeah.
Then sponsorship won't be a challenge.
Okay.
It may be challenging if you don't have a country which will support you. Therefore, there you may struggle. So you see, those are factors which may play.
Yeah.
You have parents who are able to sponsor you, that's well and good, but at our age, we are kind of past the limit of being under parents' support. Yeah. So otherwise, post is at this level in South Africa, it was still relatively easy.
Okay.
I know, for example, in Cape Town, like UCT, I know there used to be a waiting list.
Okay.
I remember when I applied, I was applying when I applied after internal medicine in 2014. That time they told me that they were going to admit me at the beginning of 2018. So that was 3 years, more than 3 years of waiting. So that was too long. Yeah. But that time when I went to Baragwanath, the post was there. I took it. Okay. Yeah. So there are certain centers which are more easy to get into. Okay. And the good thing, there are many centers in South Africa. There is in Johannesburg. There are 2 in Pretoria. There is Pretoria, there is one, and there's another one in Medunsa, probably which is not the greatest, but it also trains. The Cape Town, there are two. Durban, there is one. Eastern Cape, Free State, Free State in Bloemfontein, there is another training post.
Okay.
Yeah, so because of that variety of hospitals, it is still relatively easier.
Okay.
But obviously, with time, it gets more competitive.
Yeah. And also, I just wanted to find out the funding. Is it to fund you to be able to sustain yourself, or is it paying the university?
Oh, yeah. I think the big one is your livelihood.
Okay.
Yeah, that's the university fee are not too much.
Okay.
Because it's once off yearly payment, which wasn't crazy.
Okay.
And sometimes if you do teaching to medical students, they can also waive a big part of that.
Okay.
Yeah. So your day-to-day life living,
Okay.
that's what definitely is a problem.
Okay. Yes, and the final question, doctor, is just what do you think makes a great doctor?
Yeah, okay. Kind of a bit of a challenging question, but
Or maybe let me say this will probably go more to more junior, either students or junior doctors who haven't been in practice for long. What are some of the things that they should put in mind to become a better doctor as they gain more experience?
Yeah. So a better doctor can be defined based on who is looking at it, but overall, it boils into one thing. There is a better doctor in a patient's eyes.
Okay.
There is a better doctor in a colleagues' eyes.
Okay.
There is a better doctor as far as academia is concerned, which goes with research and so on and so forth.
Yes.
Yeah. Obviously, all of those things should kind of narrow to one thing, which is patient care, because doctors is about patient care.
Yeah.
So first of all, I will say you need to aspire to know what you're doing. Because that's what defines who you are. And that really means that you need to keep yourself informed at whatever level you are operating at, whether at intern level, whether at a general practitioner, whether at a physician, whether at a subspecialist, whatever level, keep yourself informed.
Okay.
Because medicine is very dynamic, and so keep yourself informed.
Okay.
So if one is a doctor and you don't find time to read, then it's extremely dangerous. Yeah, extremely dangerous.
Okay.
So, and that demands discipline. Discipline of saying that I need to keep up to date. And probably that calls one to try to affiliate yourself with an academic environment, because that compels you to keep yourself informed. But even a general practitioner, one can really keep themselves interested in keeping their knowledge sharpened. Yeah, because otherwise you can be very dangerous to patients if you're not informed. And if you don't read, you forget easily.
Yeah.
Easily. And then the other thing is never take shortcuts. Try your best. Try your best never to take shortcuts. Be as much comprehensive as possible. Get as much information as possible from a patient, because sometimes one small thing which you didn't pay attention to the one which may cause devastating complication into someone. So really paying attention to details is crucial. So, and avoiding shortcuts, it's a habit which one's develop at a very young age. So as you grow up in the profession, you need to develop that, because once you gotten used to shortcuts, then very difficult to go back to normal. The other thing is, obviously, if you are in a center where there is a research and you are able to get involved, it's extremely important. That's where you grow also. I know Africa, we are still very much lacking in that area. Hopefully with time we'll get exposed to like other people. So that also helps a lot. But the other thing is, in a patient's eyes is about how compassionate you are. So if you are a doctor and you have carelessness, they shouldn't go together.
It's true.
Unfortunately, we may find ourselves in the profession just because of job security. And one doesn't value the profession. One doesn't value the fact that you're dealing with vulnerable people who come to you already mentally challenged by their sickness. Because when you are sick, everyone, even a small problem, whenever you feel sick, the moment you think about is, what if these things gets more complicated and I die? So at a certain degree, you're dealing with people who are somehow traumatized. So you need to be that type of person who is able to bring a hope back into someone again.
That's very powerful, actually.
Yeah. And then the other thing is, keep yourself humble, work with colleagues. Unfortunately, we in medicine was one of the professions where we should not allow our egos to dominate. But unfortunately, they are always running behind us. And egos are so crippling because like in cardiology, there's what we call heart team. Like in many management of complex situations, there is a core to have a heart team approach, where a team of specialists, a group of doctors meet, discuss something. So it's always very valuable when colleagues discuss a patient. But in places where there's not even that expertise, people stick to their opinions, which probably are not even informed. So really be humble enough to know that this is a profession which is very humbling, and you're dealing with someone's life. So keep yourself humble, avoid inflating yourself to think that you are about on top of everything, while it's not the case. Yeah.
That was really powerful, honestly. I think I've ran out of questions now. You have really exhausted.
For sure.
And it definitely gave us a much more broader, because you would think you know cardiology, but then it's better to hear it from someone who's inside there. And in the way, we also learned even more other things that I never knew, beyond just cardiology, just about medicine. So we are really, really grateful, and I hope this impacts as many people as possible that can see it. They have a lot to take out of this conversation.
Sure.
Yeah, I would love to thank you very much, Doctor, for taking your time. I probably taken more of your time than expected, but I hope this will be valuable to someone.
Yeah. You also didn't think it would take this long, but Yeah, probably it was necessary.
Yeah, it was very interesting and necessary.
Mm. Mm.
I think I can.
There are many roadblocks.
Yeah.
There are many roadblocks
Mm.
which could have easily made me feel like I can quit.
Mm.
But perseverance and resilience to focus on your dream, and then above everything to trust God that He can take you there, was a game changer in my life. So in all that journey I was describing, there will always be challenges. There will always be challenges, but don't allow small roadblocks to define your life. Yeah, don't allow that, because trust in God and project and see that God can empower you to be whatever you desire to be. Yeah. Even now, I know I will encounter challenges at any stage, but I need to stay positive. Don't allow a small problem, a small mistake which you may commit to define your life. Yeah. But see yourself as someone in the image of God who can achieve many things when guided by God.
Okay. That's very very powerful, honestly.
Yeah.
Because in today's world where we just tend to quit everything.
Yeah. Oh yeah. No. Now I remember. I remember this story.
Yes.
So the same way I told you about that, I can't forget those who helped me.
Yes.
I also remember those who discouraged me. I'm not holding grudges, but I just remember and just laugh at it because I know human beings are very short-sighted. So don't allow someone who doesn't even know what tomorrow looks like to define your future. You see? Because for me, I don't know what will happen in the next hour. You see? So I shouldn't define someone's life based on my short sight. So when I was in my third year of medicine,
yes,
we were, I think it was like a first day in the hospital. We were doing nursing care. They used to teach us nursing care, like wound care, basic things.
Yes.
It was actually a nurse who introduced that to us. Then we went to the hospital. He was that time there were nurses who were doing circumcision. So then he asked me to assist him. So then I put on sterile gloves. Okay, it was I think my first or second time. Then I struggled how to put in sterile gloves. You know what he said? Then he said, no, you can see who will be a doctor from the first day. In other words, my failure to put on gloves was a clear indication that I will never be a doctor.
Look at us now.
You see, yeah. So this was 2004. Yeah. So and I remember many others who may look at you and say that this is a useless person. So that's how short-sighted human beings may define you. I like in South Africa, even when I was doing internal medicine, there were those who were like very rude to me, very rude to me. But when I was doing my cardiology, I used to cover an internal medicine unit. And that time I was the one who was like doing the cardiology consult, and I did it to the uttermost expectation. Then at the end, when I was finishing up, they even took me in their meeting to say thank you. But when I remember how they treated me in the
in tennis training,
you couldn't compare those two things. You
Mm.
see, things may change. Just be patient. Take things at a time, and you will see how time changes things in a big way.
That's very powerful. Thank you for sharing that experience. Yeah, that's
No. Israel, keep up the great job of helping young people.
Yes.
And yourself also, I wish you all the best.
Yeah, thank you so
and
much.
really continue the hard work and your job of helping others. That's very noble. That's what life is supposed to be. We shouldn't only focus on ourselves and we don't care about others.
Yeah.
So whatever you've achieved, my motto is whatever I have acquired with sweating, I always enjoy transmitting it to others. So that probably I may diminish the amount of suffering they have to go through.
Yeah.
So really, you're doing a great job. So keep it up, and may God bless you.
Thank you so much, Doctor. I really appreciate this talk.
Sure.
Yeah.
Okay.
Blessed. Hopefully, we'll see you soon in a year or two.
And I'm coming to Namibia mid-July to mid-August.
Okay.
Yeah.
Then, hopefully, because you are coming back to Medipark here.
Yeah, I'll be in Medipark.
Well, then I will most likely see you because I'm in Nkurunziza.
Sure.
Yeah.
Okay, Israel.
All right, Doc.
Sure, thanks.
Thank you very much.
Bye-bye.